Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Arginex.
This program is presented by Medscape Education Global.
Hello, I am Luis Querol. I am a neurologist and researcher at Hospital de la Santa Creu i Sant Pau in Barcelona, Spain. Welcome to this program entitled Chronic Inflammatory Demyelinating Polyradiculoneuropathy Care Partnerships, Aligning Goals for Better Outcomes. Joining me today is Jean-Philippe Lanson, a patient with CIDP, an advocate for patients and president of the European Patient Organization for Dysimmune and Inflammatory Neuropathies, based in France, but with the scope of all Europe. Welcome, Jean-Philippe.
Thank you, Luis. Thank you for the invitation. I'm very happy to be with you today.
Yeah, happy to have you here. And today we'll discuss the patient's perspective and the principles of shared decision-making for the long-term management of CIDP. As you probably know already, CIDP is a rare disorder of the peripheral nervous system, is dysimmune in nature and difficult to diagnose according to guidelines. It's also a very heterogeneous disease that is leading to heterogeneous outcomes and also to diverse patterns of treatment and to diverse treatment responses depending on the patients that we have. All of them share neurological disabilities, weakness, sensory disturbances, problems with gait, but apart from that, they can show very different patterns of evolution, patterns of presentation, and patterns of treatment response, and thus prognosis. To start, there is a video with Jean-Philippe, who has been living with CIDP for 25 years, and let's hear how CIDP has reshaped his life.
I was running 20 kilometers in the mountain. Now I can't run anymore, but it's not a problem. I have to adapt. Try to walk when I can't walk. Sometimes I can't walk. I don't walk, but I try to stay as active as possible because I know, and it's true for everybody. I know that being active is crucial. When a clinician tell you you're suffering from a CIDP, you don't understand, especially the word chronic. Especially you don't understand that you will have to live with this disease for the rest of your life. And for sure, I didn't realize at this moment that it was the case, that I will have to organize or to rethink my whole life around that. And but I realized probably when I had to go to the hospital to be treated, because from the healthcare professional, I was becoming a patient in the same hospital. So it was a strange experience for me. I realized that I had many questions in my head that I was unable to ask at this moment. For example, what about my daughter? What about the evolution of the disease in a short-term period? So I had to stay a long time, a while with those questions. Even if I started to see if I was able to find some information around me, which was not the case, at least in France. And I had to go to the hospital for several periods with infusion of immunoglobulins for a few days every 2 weeks, every 2 months, more or less, to see if it was effective or not. So, but it was not very clear for me that I will have to do that for a long period. It was clear for me that it was a way to be treated. And maybe I had to be treated once and it was finished. But it was not the case. It's a little bit less effective now than it was 26 or 7 years ago, but it's still working. because I've got a specific form of CIDP, mainly sensory and motor form of CIDP, it's already working for me. But it's also the reality, and because when you become older, things also are changing. The burden of the disease is real, and of course, it affected my daily life organization, if I can say so. It means that I had to, and it's already the case. I had to know, and I have to know where I will be in 2 or 3 months. Now, the interval is 2 weeks currently. We have to consider the whole journey of the patient, because if you consider the diagnosis announcement, there is a lot to do. You can't say only to someone, you've got a CIDP, see you in 2 months. No, you can't say that. You have to explain one time the D-Day, but you also have to do that a few weeks later, because be sure that the D-Day nobody understand nothing. So we need to organize that. The diagnosis announcement, the treatment and the treatment burden, what will happen, how it will work for you. So you have to, not specifically the clinician, but a sort of multidisciplinary vision of a holistic vision of the patient. It should be the holistic vision that we are all talking about for 50 years. When you are in a wheelchair, you are in a wheelchair. It's terrible, of course, but the handicap is obvious. Everybody's seeing that. If you've got a cane, this is the same. If you've got some specific devices, everybody is able to see that. But when it's more discreet, it can be very burdensome for the patient, really. The way that I was seeing myself internally, I mean, I was a young 30-year-old man and so on, but also for my wife, because we were youngly married, so she had an husband with a disease at this time. I mean, so she married an healthy guy, and then few months later, she was with a young man but with a chronic disease. So I had also to deal with that.
So thank you, Jean-Philippe, for sharing your story and pathway with your disease. Now we are going to talk about the goals of treatment in CIDP, specifically on treatment. Sometimes we clinicians have an idea of how to approach a patient and how to define what we want to see in a patient, but what are you expecting as a patient? Which are the goals that a patient expects in CIDP?
Yeah, thank you for the question. But the first goal for a patient is to be treated, to be cured initially. But when it's not possible, we want to have a treatment with a very important effect on symptoms. I mean, when we are talking about CIDP, as you said, we are talking about heterogeneous disease, a complex disease with an impact of the motor abilities and sensory abilities as well. So as a patient, I'm expecting to have a treatment effective on that. For example, if I'm unable to use my arm, or if I'm unable to walk, if I'm unable to shave myself, I want to have a treatment effective on that to have a normal life. We want to have an easy access to the treatment. We want to have a treatment with a very small burden. And you, Luis, what are your goals? What is your goal when you want to treat your patient?
Yeah, it's good that you ask that. In principle, the goals are the same as the ones that you have. We would love to see the disease cured. That this is not possible at this moment, not for most patients. But I think it's important that you ask this question because, yes, the goals are the same. So we want the patients to go back to their lives, to be able to perform the usual activities with the less amount of burden possible. Sometimes the difference between us both comes on the way we measure these things. So for some patients, it may be very important to be back on the work, and for us it may be recovering the strength of the arm, which is not exactly the same thing.
That's true.
And that's important because that's how we focus on those things to assess on the scales that we use that are the practical way of seeing the goals in place.
So Luis, I have a question for you. So what have we achieved with treatment so far, and what have we not?
Yeah, that's a good question. We have achieved a lot of things. So first of all, this is a treatable disease. We have treatments available in the market and that are useful for a very significant proportion of patients. We have drugs that are um, effective to some extent in more than half the patients. We have also different types of drugs, and we have ways to diagnose the disease that are relatively available for everyone. Uh, on the contrary, we also need some improvements. We still have some unmet needs, starting with treatment themselves. So first, despite they are useful, some patients are not responding to any of the available treatments yet. We have immunoglobulins, we have corticosteroids in combination. They account for a lot of responses, but there still are refractory patients that need to be addressed. Second, those that respond may respond incompletely. Maybe they have some residual damage. Maybe they have some weakness that is not improving completely. And also they can have residual symptoms that are not susceptible to treatment, like pain or fatigue or other collateral symptoms. And finally, we also have the burdens related to the treatment itself, because we may have a good response, even a very good response, but with having to suffer some of the inconveniences and of the burden of the treatment, including let's say administration burdens, difficulties in access to the veins, side effects. This burden depends on the treatment. Something that is important to note is that we are having a lot of research in the field, and this includes therapeutic research, and there are new drugs that are already approved in the European markets, like, for example, efgartigimod, or, for example, other drugs that are currently under clinical trials. So we have good landscape that, of course, will also have its own challenges, but I think we will solve part of those unmet needs that have not been met yet. But that's from the clinician's perspective. What are the hidden burdens of therapy and the things that we still need to improve from your perspective?
Thank you for this question, Luis. Well, there are many burdens when you are a patient living with a chronic disorder like a CIDP. If we are just focusing on the treatment, and if I can talk about my own experience, I'm under IVIG for 25 years. I have to be infused every 2 months, which is correct for me. But of course, it's a huge burden because it means I have to know where I will be in 2 months. Would I be able to go to a hospital to get my treatment because I'm treated at home, and I'm fortunate to be treated at home? Then it's a burden regarding the access to the treatment. First of all, it's a burden regarding the way that we organize everything at home. It means the material, everything, the electronic pump, and so on. So it's a burden for a patient because I need to find a dedicated place in my house for all the material. And then I have to find a nurse to put in my vein a catheter every 2 months. But it's a burden that I accept because the treatment is effective for me. Even if we consider the huge burden, I have to stop working every 2 months, for example, because in my case, once again, I'm a little bit fortunate. It's every 2 months for 3 days, but for most of the patients that I know, it can be every 4 weeks for 5 days. So it means every month you have to stop your life for 5 days to be infused, which is a lot.
Yeah, that's a good thing that you bring all those things, because maybe those are the things that we as physicians don't focus so much on. We are focused on efficacy, we are focused on the immediate things that we want to see from the treatment, but sometimes these other things that are more related to the burden are not taken in account so much. And sometimes we don't understand this paradox of having patients that we think are doing really well in terms of efficacy, but that are dissatisfied with treatment. Of course, they are satisfied with the response, but they have all these complaints regarding the collateral aspects of the treatment, and we sometimes don't pay attention so much to these ones.
No, you are the expert of the disease, but we are the expert of the life with the disease. So we need to work together.
Sure.
So Luis, you were talking about several treatments and the efficacy of the treatments and about the heterogeneity of the disease. How do you recognize a suboptimal response and when a therapy change should be considered for a patient?
Yeah, that's a difficult question. So it's an art sometimes. Of course, the first thing is asking the patient, how are you feeling? And sometimes the patient is giving you clues that the therapy may not be going perfectly well. For example, there are two key things that can come from the patient. One is a slow decline over time. There may not be a relapse as we know it, severe worsening of the disease, but maybe more subtle. The second one is the fluctuation. Sometimes when a patient fluctuates, both subjectively, but then when we confirm that this fluctuation is true objectively with the clinical scales, etc., that probably means that the treatment is not working perfectly, or at least it's having some areas of improvement. Then it comes a little more the art of the neurology. Sometimes you see muscles that are weak, relatively weak, that are not atrophied, that don't have severe axonal damage, which means that maybe those muscle groups can be improved with in optimizing the treatment. And sometimes it's newer things that are not yet available for widespread use, like the biomarkers. If you see a patient that has, for example, axonal damage with a neurofilament light chain or other biomarkers, then it might mean that the treatment is not good enough at addressing this axonal damage. So a combination of the patient's feelings and subjective experience, plus the scores and the clinical scales, and some of the tests like the electrophysiology and the biomarkers, gives us the idea that maybe that patient needs a treatment change. Sometimes it's very obvious. If a patient is doing a relapse, even after treatment, then it means that the treatment is not clearly effective. But sometimes it's more subtle, and these are the challenging cases, which may be sometimes more frequent than we know. And of course, we manage this by different approaches, either by changing completely the treatment, or by doing dose adjustments, or by changing the route of administration that sometimes may be useful to handle these fluctuations, like, for example, with subcutaneous or other formulations. But that's about efficacy. So how do you patients know, or how do you patients manage the treatment burdens, and when do you lose, let's say, confidence in the treatment? What are the key things that you, by your experience or by asking other patients that you know, have led to a treatment change?
It's a complicated question, as we said, that's true. But for a patient, I think, once again, the efficacy of the treatment is probably the first thing that we have to consider. Then, when the efficacy is not at the rendezvous, we have to consider something else. I mean, the burden of the treatment. If we are considering, for example, IVIG, mainly for CIDP patients, we are talking about high volumes of injection for a long period. Each infusion can be between 3 and 5 days, more or less. All depends on the patient, of course. But it means that you have a catheter in a vein for 5 days, receiving a high volume of PDMPs, plasma-derived medicinal products. Then, if the efficacy of the treatment is not real, for the patient, it also means that maybe it's the moment to find another opportunity or another option for the patient. Then, as you mentioned, there are several options for patient. Corticosteroids, For patients, it works pretty well. But we know that if we consider corticosteroid for a long period, it can be tricky if we consider the side effects. But if it works, it works. So no use to change. If we consider immunosuppressant, which is more complicated to manage probably, and you know that much more than me, of course. But if it works, well, let's just keep it. But we all know that if we consider this immunosuppressant, for example, there are many side effects that we also have to manage as a patient. So currently, there are no ideal treatment. The ideal treatment is the treatment with the most important efficacy and the less side effects. So all depends of each patient. If you consider the subcut, for example, for immunoglobulins, well, it can be interesting for patients. They can manage by themselves their home infusion, for example. But for other patients, it's a huge burden. So I think it's also a question of shared decision making.
Yeah, sure. In fact, on top of all those things, so there's the efficacy part, there's the burden part, and then we have to add the external things like regulators, the guidelines, the recommendations, the payers, the availability. All those things are part of the mix and bring us to the shared decision making, which is sometimes something that we don't take that much by focusing only on the physician perspective. We don't see all these other things when we need to discuss whether a patient is okay by doing injections or not, or is okay, or it would prefer immune suppression if that is associated with better efficacy, or the other way around, if they prefer less efficacy but not having to get immune suppressed. And so I guess this is a discussion that needs to evolve as well as the disease evolves, and we are not sometimes completely aligned, but hopefully more so in the future.
So Luis, considering the monitoring of your patient, we know that sometimes it can be complicated to monitor the CIDP patient. How do you work regarding the monitoring?
Yeah, so monitoring is a very important part of the process. There are several tools and paradigms, but first of all, we need to be clear that monitoring is something that needs to be having the two experiences: the subjective experience of the patient and the scores and clinical scales that we usually take in account to decide whether or not a treatment has worked, or is working, or has not worked, and it's failing. So first thing, now we have a novel paradigm to monitor patients, which is defined clearly in some documents that we are now writing in the guidelines. But so far, imagine the patient perspective was not completely incorporated. Can you imagine? But now it's incorporated into the monitoring as one of the major drivers. So now, once we have the patient experience, are you feeling better or not? Are you feeling the same or not? Then we apply the scales, and the scales need to be stable or improving, depending on which is the objective. If the patient has already improved, then we want the patient to maintain this improvement. And if the patient was doing poorly or was in a relapse, then the objective is to improve the patient. And that we monitor with the scales. Then we also use some other tools. We were mentioning before some biomarkers, we were mentioning before electrophysiology, but those are secondary points that are not considered currently the main drivers of the monitoring. And finally, the other important thing that we need to do with the monitoring, because we are talking about efficacy, is again ask the patient about all these other issues that might not count for the scales, like pain, like fatigue, like burden of the treatment, etc., that are also drivers of the decision regarding a treatment. And finally, the other thing that we need to do sometimes is assess whether or not the treatment is needed at that specific point, because there is a proportion of patients that enter into remission And then the other big decision that we make when a patient comes to the consult is, does this patient need the treatment, or can we taper it down? Can we withdraw the treatment completely, even because it's not needed anymore because the patient has entered into remission? So those are the monitoring processes, which are very similar across treatments. Of course, each treatment has its own specificities. So in IVIG, you focus a lot on fluctuations. Maybe we don't do that in other treatments like rituximab or subcutaneous IG or corticosteroids. And in corticosteroids, we focus a lot in the side effects and some tests like glucose levels, etc. And we don't at all with immunoglobulins. So each of them has their own specificities, but in general, the paradigm is this one that I just mentioned. And with that, I think we are coming to an end. So thank you, Jean-Philippe, for this great discussion and for sharing your story with us. And thank you for your attention. Please continue on to answer the questions that follow and complete the evaluation. Thank you very much for your participation.
This program was presented by Medscape Education Global.